So we have some collaborations with people at the Children's Hospital. I'm an adult physician. MDS is really an adult disease, but we have collaborations with some groups there, and we also have collaborations with groups in Sydney at the Children's Hospital and the Children's Hospital Research Foundation down there. When I trained in Boston, I trained with David Williams, who is the Director of Pediatric Haematology and Oncology at Harvard. So I trained at the Children's Hospital over there and was in the pediatric department predominantly. I think there is some overlap, but myelodysplasia is really a disease of adults.
Yeah, the research for AML.
Yeah, there's one group at the Children's Hospital in Brisbane that are doing research in acute myeloid leukemia, and we've collaborated with them a bit. We share a lab meeting, we share a data club meeting with them once every 2 weeks. So there's certainly some interaction there.
In that time?
So it's probably about 40 years that we've been treating patients, 45 years we've been treating patients with AML with intensive chemotherapy and getting cures.
Yeah, right.
AML, again, is far more common in adults than it is in children, but AML can be seen in children as well. Yeah. It's the second most common cause of leukemia in children, but it's far and away the most common cause of leukemia in adults. So for some reason, children tend to get a disease called acute lymphoblastic leukemia. Fortunately, that one responds very well to chemotherapy, and a lot of patients, probably about 85% of kids, are cured these days. Whereas in adults, AML can be cured with chemotherapy in about 40% of young adults. So that's people under the age of 40 to 50. But in patients that are 60 years and older, it's very, very difficult to cure. I mean, there's been huge developments in the last 40 years. And there continues to be big developments.
Do you know exactly why some people get it and others don't, besides the gene factor? Like, I come from a family that's no leukemia anywhere down through the generations, and my GP picked up.
So that's, I don't believe that's what causes it.
Okay.
But obviously everybody has their own opinions, and they're certainly entitled to that. What happens as we get older, and this has been proven experimentally, is those blood stem cells that we have when we're young, they live throughout your entire life in the bone marrow. And as they divide, they make a new copy of themselves, and they make a mature blood cell that goes on into the blood. But as they make a new copy of themselves, they have 24,000, 26,000 different genes they have to transcribe absolutely perfectly. And as we get older, their ability to proofread the errors becomes impaired. And they start picking up little errors. And the reason this happens so commonly in the blood is that they have to divide so aggressively and so many times during the body. So as they pick up little errors, those errors may control things like the way that DNA is repaired down the track. And so you get additional mutations that come on. And so generally speaking, when you're less than 20 years of age, if we look at the blood stem cells, they don't have any significant errors in them, in the genes. But as we get to 40 years of age, they might have 1 or 2. And by the time we're 60, they usually have 6 or 7 different errors in the DNA that controls them. And unfortunately, it does tend to be bad luck that if one of those errors happens to be in a cell that causes that cell to start growing much more rapidly, or it basically causes it to be what we call immortalized, which means it can never die, then that precipitates the initial change to either MDS or AML. And that's probably the reason why it happens much more likely as we get older. It's probably the reason why blood cancers are so common, because these are cancers of rapidly dividing cells in the body. And unfortunately, there's no good evidence to say that viruses cause it. Certain lymphomas are probably caused by viruses, but not in AML or MDS. And it's difficult to know how other medical illnesses or stress may contribute to it. I guess there are all sorts of things, what we call environmental factors, that control our blood development, including jet lag and including sleep deprivation can actually affect the way that your stem cells live in the body and go around. So there's lots of external things that can affect the stem cells, but it's never been shown that that causes leukemia. So the chemicals, environmental chemicals, including pesticides, almost certainly do have a higher rate of causing blood cancers. In my experience, I would say that we see lymphomas much more commonly in people who have been exposed to pesticides and chemicals than leukemia per se. But there's no, I think that's been conclusively shown that those sort of chemicals that can damage the genes in the body, and that's how they work, can actually cause blood cancers. There's a lot of debate about how long people should remain on azacitidine, but generally speaking, if you're having a response to azacitidine, then you stay on it until the response is lost. It can be a number of years.
You've got no knowledge. I know everybody's different, but are there any figures that some people can last 4 years, some people can last 2 years, or?
Yes. Yes is the answer. They're exactly those figures. Some people don't get a response at all, and they're off within 3 months, or even less than that. And in fact, the government will only provide 3 months worth of azacitidine, and you need to demonstrate that your disease is at least stabilised, or they won't provide any more of it. And it's a very expensive drug, as we know. It's probably $60,000 a year. It's very expensive. All of these drugs, these new drugs, are extremely expensive. And people who have a good response and maintain that good response can safely stay on it for a number of years. So those trials have shown that some people may be just a month or two, and some people may be 3, 4 years or more.
Because I'm responding very well to it, but I'm in my second stage of the 6-month period.
Yeah.
I'm not quite sure about stem cell transplant at this point in time. So what I'm trying to do is get figures, if there's such a thing, on people who have responded well to ASAs, or let's say a max of 5 years. And I don't know if the government will allow you, even though you're responding well, will allow it to go on for that long because of the cost factor.
The government criteria. So yes, there are people who are treated for a number of years on azacitidine on those trials.
Okay.
And the government criteria to stopping funding is losing your response. It is not a number of time. So while you maintain a response, you can be treated with that drug. What it does show, though, is that around about 50% of patients are not able to be treated for 2 years or more because of the loss of response. So the majority of patients will respond. That response duration can be a number of months, or it can be 1 or 2 years, but it is uncommon to people who have sustained responses that last 4 or 5 years. It's very uncommon for that to happen, but it can happen rarely.
And, okay, work on the basis of a 2-year period. After that 2-year period, is there anything else you can go on to, or that's it, excluding stem cell?
So at the moment, there are limited new drugs available through the PBS. There's lenalidomide or Revlimid in some cases, but it's not funded unless you have this particular chromosomal abnormality. There are new drugs that are coming, but they're not currently PBS listed or funded at the moment.
What about, do you know anything about overseas?
Yes.
USA, is there anything over there, or Europe?
So there's a bunch of stuff coming through clinical trials. Decitabine is listed in the United States. It's not listed here. So these are other drugs that are available, but they're not widely available here at the moment. So
Can you explain what you mean by response to the azacitidine? Because I guess we're understanding that the goal of the azacitidine was to go into remission in preparation for transplant.
yeah, it's uncommon to go into complete remission.
It's uncommon.
It's uncommon to go into complete remission. So the azacitidine, I mean, the government funds you on azacitidine while you don't get worse. So that's what they require. They require you to not get worse. But if it develops from MDS to AML, then they say that's getting worse and the drug's not working, so they won't continue to fund it, which I think is actually a very reasonable approach, because if a drug is not working and you're getting worse on the drug, then you need to think about something different. So there's two different ways to be called a responder to azacitidine. The first one is that your blood counts improve. So if you're anemic, it means you become less anemic, or maybe even don't require transfusions at all. Your white blood cells might improve, or your platelets might improve. And we in fact see this in the majority of people treated with azacitidine, that they have some sort of improvement in one of their blood counts. But the rates of complete remission are low. So that's the people who have MDS, get treated with azacitidine, and you look at the bone marrow and it looks completely normal. And the cytogenetics or the chromosomes that were abnormal go away completely. That's very, very unusual for that to happen, but it can happen. So I guess when I treat people with azacitidine, I tell them that the goal of treatment is to improve your blood counts. And if we get anything more than that, we're very happy, obviously.
So it's common to have azacitidine and then go to a transplant?
Yes. If you're deemed transplant eligible, it's quite a good bridging strategy, but it's not a definitive curative strategy. Thank you very much.